Hi everyone, thanks for joining so far. We'll just wait a minute or two just for the last few people to join and then we'll get started.
In the meantime, we could sing the NNAP song, couldn't we?
You'll have to introduce us to that one, Sam. I don't know. I don't think I know it.
Goes like this.
Okay, I think the admit button has stopped pinging or slowed down at least. So we'll get started and then the last few people can join us as we start. So welcome everybody and big thank you for joining this webinar this afternoon. It's really great to see so many of you. Know it's not the most exciting of topics, but we get excited when people are interested in the data, so that's great. Just a reminder that we'll be recording the session, so it's available to watch back later. We've muted your mics and got your cameras off for now, just to help with bandwidth. We will enable your mics when we do the Q&A session, but if you can just keep them muted if you're not talking, that will be really helpful. Thanks. So just to recap the aims for the day, and I'll go to our agenda slide. Just going to move on. But not. Should have an agenda in front of you now. So just to recap aims for the day, we hope by the end of the session you'll understand why we're asking you to validate your data, some of your NNAP data, and how you can go about doing it practically. Sam's going to talk you through doing that. And then we'll cover some of the changes to NNAP reporting that have happened recently and that are going to happen in the near future. We'll hear from Dr. Lawrence Miall at Leeds Children's Hospital, who will talk about their experience of validating and reviewing their necrotizing enterocolitis data and how they've collaborated with other centres to do that. So once we've heard from Sam and Lawrence, we'll dedicate the rest of the session to your questions and answering those questions as well. So you can have an opportunity to ask questions about what you've heard or anything else that you want to know about the NNAP. So Sam, I'm going to unshare my slide and invite you to present. So let's stop sharing. I expect most of you already know Sam. He's been NNAP clinical lead for, I think, coming up for 10 years, and is now also neonatal clinical lead for the National Maternity and Perinatal Audit hosted by the RCOG. And Sam's a consultant neonatalist in Bradford. He usually introduces himself as a reformed Southerner. So I'll hand over to you now, Sam, if that's okay.
Yeah, absolutely. I think by the end of this session, because you've always got to have objectives, I think the objective is going to be that we'll unmute you all and get you to sing on the NNAP song, which is, of course, as you all know, always look on the bright side of life, first performed by Monty Python. But really, I'm here to do something much more drab, which is to try to talk you through the data validation process, and specifically I'm going to tell you some things about how I approach that. So I wanted to share how it works, how the process works. I want to talk a bit about what measures need validation and how specifically how I go about do that. And how we use your amended data, or rather when that's visible, when that will be visible in our reporting. And as Rachel said, I'm going to talk about a little bit about the reporting changes that are coming. So it is very much a process. I think everybody probably on the call is familiar with the concept of what we in-house call the Q reports, so the quarterly reporting. So I've represented that in my very shonky slide here. So the NNAP data complete quality and completeness report. And so you can see this is Bradford's report for Q3. And the original intention of this was about completeness, but it's very much about quality as well now. And it's intended to show you how the data that you put in Badger, well, currently it's only in Badger, how the data that you put in appears to us as we get it out. And in addition, we can show you some comparisons to national average, and we hope that's useful in terms of stimulating quality improvement and telling you when things are going off, as for example, thermoregulation in my hospital has gone off a little bit in recent times, and we've then done something about it. The reports describe the missing, so where, for example, temperature data is missing, where it's non-adherent, so the baby's either too hot or too cold, and it shows where you're adherent to given measures, and it also describes the identities of those cases, and I'll show you some examples of that. And then the process then goes on to Q1, Q2, Q3, Q4 reports at the end of the year. And so that's actually coming up quite soon in the next couple of weeks. We'll be issuing our Q4 report. And that is how the data for the whole of 2022 in this most recent case looks to us. There's then a period where you can make final amendments to that data, a 6-week period. And during that time, there's a data validation survey, which I'm not going to show you an example of, but in effect, we send a survey monkey around about particular measures, saying, are you confident that you've cleaned up your infection data? Are you confident you've improved your BPD data, your NEC data, and indeed brain injury too? So here's an example of the quarterly reports. This is obviously Bradford. The first thing I wanted to point out to you is that when we change the measures, which from time to time we need to, the quarterly reports describe the most recent updates. I'm guessing most of the people who are on this call are familiar with the idea that we've changed the NNAP steroid measure. So that's updated for 2022. And so the measure points you to that. We got a lot of queries, as you'd expect, about NNAP measures, and most of those are addressable by looking at the measures guide. So here's the 2022 measures guide, and this is relatively recently amended, but the amendments are fairly minor. But we try to describe what we're doing with the measures, and also the why, and the attribution. So, for example, which unit gets to take credit for a particular baby's process or outcome. So the quarterly reports, I keep pressing the wrong button on my computer, but we'll get there. Quarterly reports in this example of antenatal steroids say what proportion of women were antenatal steroid exposed in Bradford, 43%, and they highlight that this is a little bit below the national average, and you can see the national average figure is 49%, and it describes how many mothers form the denominator and numerator and the number of missing data. And there's a what you should do next section, which in effect this webinar is a little bit about all of that. So I've got the circle of death at the moment. Here we go. So we'll just go back. So that's an example of the quarterly report. And here are the spreadsheets that come out in the SharePoint folders to those of you locally who are nominated as your NNAP contacts. Now, it may be that you think you're in charge of NNAP, but you don't get this, or you don't get the report that I've just shown you, in which case, just email us and we will add you to the contacts for your centre. But these are, this spreadsheet becomes visible in SharePoint at the same time as the quarterly reports. And I'm showing you here the page. You can see down the bottom of this page here, there's lots of different tabs for different measures. I'm showing you the antenatal steroid page, and I've altered the columns so that you can't see the identity of any of the patients, but it tells me the outcome for all the patients who aren't, in this case, adherent to the measure. So there's a baby at the top here who's apparently got complete steroids courses, but got the last dose of steroids after the baby was born. So there's something not quite right there. Somebody's perhaps put the wrong date in, and that's data that needs cleaning up. And you can see that there's a timing of the last dose that's blank, and so again that's missing data, it's incomplete data. And so You can see for each of these measures, there are slightly different categorizations. But the idea is that this allows me to take the identity of these patients using this column C here, to drop that into Badger, and I can find the patient and amend the data if it's inaccurate. And most of this is missing data, so there is therefore some level of inaccuracy. Usually it's been not done. I'm aiming not to take very many minutes in talking to you today, but I wanted to kind of ask the question, what measures do we validate? Because there's quite a few measures. You'll see all the measures on the screen. We've antinuclear steroids, magnesium, deferred cord clamping, thermoregulation, 2 parental measures: parental consultation, parents on ward rounds, retinopathy of prematurity, long-standing area of interest for NNAP, breast milk feeding at day 2, day 14, breast milk feeding at discharge, type and duration of respiratory support, bloodstream infection, BPD, NEC, brain injury, follow-up, mortality, nurse staffing, and there's something about demographic completeness. And this is a session for detail addicts like myself. So we're very interested in the demographics of the babies described by NNAP, because there's a lot of emphasis in the NHS at the moment about making sure that healthcare users of, for example, minority ethnicity don't get a raw deal. So if we don't count the we're talking about specifically ethnicity and postcode, a measure of deprivation, therefore poverty. If we don't include that data, so we need to know the ethnicity of the baby and the mother, then we're not able to do those analyses. So we think that's an important one. So which measures? What should we actually do? Well, you can see just on demographic completeness, that's not something that, in all honesty, in Bradford, I have done much about. I believe that the data is reasonably complete, but there's probably more that I could be doing in terms of my data cleaning, in terms of demographic completeness. I'm going to focus a little bit on what I do, because understandably, I've given this quite a lot of thought. It doesn't mean it's the only answer, but I think we're all aiming to have very complete data with very low amounts of missing data. So I'm going to talk you through all the measures, and I'm going to do it actually from the top, having started from the bottom. So I've indicated that I review all the babies who have missing or unknown data for antinuclear steroids, but I actually review all the cases where the mum is said not to have had antinuclear steroids, because I think that's a really important area for us, and it doesn't represent an enormous amount of work. I do that in concert with my preterm review group in my hospital. We look at all the preterm deliveries to look for themes of potential improvement. And so the steroids and indeed the magnesium and indeed the deferred cord clamping data gets cleaned in that meeting, or before that meeting. For the thermoregulation measure in NNAP, I review all the babies where the temperature is apparently taken late, because that's usually a data entry error. I review all the cases where the baby was apparently cold, because sometimes that's a data entry error, and I review the data where the baby is hot, which is frankly not usually a data entry error. I'm absolutely obsessional about how I do that and the honesty with which I do that. I have a clear set of internal standards, and I'm very, very clear about not telling a lie. I think if it would only be my own time I was wasting, I might say. The parental consultation measure, I review all the cases where we either appear not to have spoken to the families, or we haven't entered any data about it. And we've got our missing data down to a pretty low level. I have to say that we were stimulated to do this, having been quite good at parental consultation, but not perfect for some years. Everybody else got a lot better, and we started looking bad compared to the rest of the pack. And in fact, we were a low outlier, so that was fun. We've improved significantly with the help of our ward clerk. What I don't do in Bradford is do anything about cleaning the data for parents on ward rounds. because there's an enormous amount of that data. And I perceive that's a focus for the future, something that I hope that we might get a whole team response to rather than that just fall into me. For retinopathy of prematurity, something that I know a lot of you have spent time cleaning data, making sure it accurately describes what goes on. Again, I know the level of honesty that people apply to this. They're very clear about whether screening did or did not occur in the window, and that's how we describe the relative success that we've had in the past, and clearly we're seeing different figures this year with the new measure. So I review all the missings and all the cases where the baby was apparently non-adherent. I don't review them if it's apparent we apparently screened the baby on time. I don't do anything about cleaning the breast milk data at all. And I don't clean the type and duration of respiratory support data, although there's very low levels of missing data for me in that. So that leaves some. Okay, is that a message for me? No, I think it's not a message for me. That we've got some outcomes in the second column of measures here. And bloodstream infection is an area where we know that data incompleteness. Yeah, we're still on the same slide. Yes, it's hard not to respond to the chat. Bloodstream infection is still is an area where we really struggle to. We know that it's easy to end up missing out a positive blood culture, and so I seek assurance from my colleague who runs infection surveillance in my unit, and I know, because I shared an office with him for many years, that he thinks he enters all the blood cultures, and I seek typically quarterly, but certainly at the end of each year, assurance that every single positive blood culture has been entered into Badger. And we do that with a download that we get from microbiology, so we ensure that that's the case. I don't clean the bronchopulmonary dysplasia data at all. I perceive that the rate of missing data is very low. We do have a nurse who looks at our dependencies and cleans some of the daily data, which contributes to the BPD measure for the use of oxygen or otherwise. And so I think there is quite a high level of looking at that, but I don't clean that data specifically with regard to NNAP measures. NEC I'm going to talk about in a little bit, and the preterm brain injury measure I'm going to talk about in a little bit. So I'll skip over those for the time being. The follow-up measure, we review all the cases where it appears that we have not carried out neonatal follow-up. Indeed, that's been quite productive, because sometimes the children are seen in our child development service rather than in the neonatal follow-up. And so often structured neonatal follow-up has been done, but just not by us. So we find it helpful to go back and review the apparently non-adherent cases. So for those who are bored with my very boring slide, I'm going to try to move it on, but I failed to do that. So this is where the analog system of medical record keeping in Bradford becomes apparent. So this is the purple bag of notes, which looks blue on this slide, that is currently sitting about 18 inches to my right. I need to pick up physical notes in order to do this validation much of the time. Not always, but particularly for parental consultation and ROP screening, for example. So that involves my ward clerk colleague Asif and myself working together, looking through notes. So I want to talk about two measures in particular. So brain injury, so a relatively new measure. We've focused on rates of babies with grade 3 or 4 IVH and also on rates of babies with cystic PVL. In order for that data to be accurate in Bradford, I know that I need to look at every single baby's record. So the way that I do that is I go through the Badger or discharge letter for every baby, and depending on what's written there, I often end up looking at the radiology system. The way I review the letter, I do that in a structured way. I look at the headline diagnosis. I read the summary section of the letter, I'll read anything that's been pasted into the CNS section. I find that if there's indication that there may have been any brain injury, then I often need to look at the radiology reporting. And it's particularly important that I establish whether the grade of IVH and the presence or absence of cystic PVL has been accurately described in Badger, and I find that's not always the case. And I mostly don't look at the images, I mostly look at the reporting. And then I use the spreadsheets that are set out, which I save separately, and I then make a comment on it. And here is my colleague Aishin Locke, who's actually doing some of this work this year, and myself. And we've often done this as a learning exercise with a trainee, so we'll compare notes. And then we'll make a record, as you may be able to see here, about what changes we've made to Badger. So I think it's really important for me to look at all of the cases. I can't see any other way of us having a hope of describing the outcomes accurately without doing that in my hospital. Maybe others are much better than this. So Lawrence is going to talk a little bit about NEC. And we know Lawrence and I are a good colleague. Well, he's a great colleague to me. I hope I'm a good colleague to him. I know that we do this differently. I review all the babies in a way that is similar to the way that I look at the babies of the brain injury outcome. And I review the letters of all of the babies. The 30-week 1,800-gram babies, I do look at the letter, but I don't look anywhere near the level of detail that where there's a suspicion that NEC or some kind of abdominal event may have occurred. And Lawrence is going to talk some more about that, so I won't say anything more about that. I'd say something about the future of NNAP reporting, because what I've described so far is an annual reporting model, where we're asking you to get your data, your Q4 report coming out in the next couple of weeks, and you've got 6 weeks to clean the data, and we'll then analyze it and then submit a report to HQIP, and then ultimately publish it in the November. That's been our typical model, and here you can see that described here. The data validation survey will be coming out in February, March. We'll send that out repeatedly until you answer the questions. There'll be a final deadline for the data to come into Badger, and in the end of the year, we'll publish an annual report. Of course, meantime, you're living your real clinical lives, and you've got 2023 babies coming through, and we'll be issuing a Q1 report via the SharePoint folders in May. In June, or possibly July, but hopefully June, we'll actually start reporting the data more frequently, and I'm going to show you an example of what that's going to look like in a moment. That will initially just cover what we call the POP6, the perinatal optimization pathway. So things like thermoregulation, deferred cord clamping, magnesium sulfate, and the like. And so we're going to show, we're going to start releasing data in much closer to real time, quarterly to start with. So we are contractually obliged to release data into the public domain quarterly from 2023. And we are contractually obliged to consider doing that monthly. So that's quite a difference to the annual reporting that I've been talking about. And we're going to do that in a staged way. And we will in the end get rid of NNAP Online and move entirely to this new platform that colleagues have been developing. So we're going to do that in a phased way, as the slide makes clear. The POP6 metric and a composite measure will come through in June 2023, and there'll also be public-facing data. So, and I know that in England, at least, a lot of us are getting a lot of encouragement to clean this data in much closer to real time for academic health science networks and neonatal networks to be keeping an eye on. But it's clearly going to be a challenge for all of us to keep our data nice and tight. But we'll be releasing that quarterly to start with. And there will then be a further iteration of the public-facing dashboard to include some of the following measures: consultant ward rounds, breast milk on day 14, 2-year follow-up, ROP, nurse staffing, and type of respiratory support. And of course, when we release the any output, the data behind that will be there. So this, if you like, the spreadsheets coming through Quarterline, like the spreadsheet that I showed you an example of. And then finally, phases 3 and 4, and this is more like next year and the year after, we're going to think about monthly reporting. We're going to think about the viability and the utility of that. We need to be careful to listen to what's said about this, and we need to, and we'll be trying to put outcome measures out there as well. So how we're going to do this? Well, the technical stuff's being done in Power BI, so I can spell that, but that's the limit of my knowledge. We will reanalyze all the data that we hold using the new code. So it's possible that it will look like a tiny bit different to what we've previously published, and we'll just need to communicate clearly about that. There is clearly some risk of deductive disclosure, and that means people will be able to establish something about patients who you've cared for by the data that is put in the public domain. We've, as you can imagine, got a policy on that, and we're going to manage that differently for different measures. I'm going to show you a prototype. So this is intended to look quite similar to the parent the posters, poster 1 and poster 2. So there'll be a prototype dashboard, something like this, and apologies to the people who made these nice graphics which have got squashed on my slide. But you can see, I think, that this is some Bradford data, and this is what the dashboard will look like. And there's a composite metric down in the bottom right hand side here, which is the proportion of babies born in the period of interest who got all the measures. This will default to quarterly, but here we've got a year shown, and you can see that relatively few babies get all the optimization measures that they're eligible for. The national figure is in black and white, and the Bradford figure is in blue. So that's what the front page will look like, but we know that might be of interest to perhaps a casual reader, but we know that if you want to change stuff, you will want to know what's going on in real time. So here's an example of this is a prototype, and it's not yet fully designed as in within colors and the like, and I appreciate it's reasonably complicated. So the green line is the national proportion, and here you can see it's 2016 to 2022 on the horizontal axis in the main panel. The green line is the national average, and here's Bradford. From quarter to quarter, quite a lot of change going on, bouncing around a little bit, but you can see well, you can make your interpretation, and my interpretation, for what it's worth, is that that's not too worrying. But I can see real-time changes, and there's a consideration going to be done to doing this monthly. The grey describes the middle 80% of units, and the light grey, so the light grey is the middle 80% of units. The dark grey is the middle 50% of units. Very importantly, you can see that there's quite a lot of missing data for this particular measure, and that's not really surprising, given the steward measure that we're talking about, which depends on date entry. But when you look at, if you look at other measures, you'll see that there's that missing data contributes quite substantially, and quite substantially to composite metrics in particular. So I'm getting a signal to Rachel from Rachel to get off, so I will. But you can see that there's a gestational age breakdown, and we've worked this up, and we're going to move to user testing. We thought it'd be good to show you. So pressing the wrong button again. So in summary, I hope I've given you a little bit of a vision of the future, but also talked about, I hope persuaded you that cleaning the data is important. And in doing that, we want you to use the quarterly reports, the spreadsheets that are associated with that, to note the deadlines, which of course are in the not in the spreadsheets, in the quarterly reports, and it will be very helpful for us to get prompt replies to the data validation survey. And we hope that you'll enjoy the evolving reporting and not have to lug any bags of notes around. So thank you very much for listening. I think Rachel's going to direct.
Thank you, Sam. Yeah, there's lots of information there, and I'm sure you'll have lots of questions for Sam. If you can hold those thoughts for the moment, we'll hear from Lawrence, and then we can have questions for Sam and for Lawrence afterwards. I'll invite Lawrence to start sharing his slides. Lawrence is a consultant at Leeds Children's Hospital and NNAP lead for his service. Lawrence is going to talk to us about their experience of validating NET cases. So I'll hand over to you, Lawrence. Thank you.
Thank you very much, and thank you to Sam and the team for inviting me to contribute to this webinar. So as you say, I work in a regional NICU, and we have surgery and cardiac babies on site. So we take the NEC babies from around the region, and work closely with my friend and colleague Sam in Bradford to discuss some of these cases. So just to remind you what the NEC measure is for this last year, it's babies born below 32 weeks gestation who survived at least 48 hours after birth. And the baby then needs to meet the NNAP surveillance definition for necrotizing enterocolitis on one or more occasions. And the baby is attributed to the hospital where they were located at 48 hours of life. And obviously this is intended as a proxy measure for the intention for ongoing care during the kind of critical weeks of a preterm baby's life. But you'll see that that's very relevant when you come to look at the data. Just a reminder of the surveillance definition, which I'm sure you'll all be familiar with. But NEC can be either diagnosed at surgery or at post-mortem, or it can be based on one of the following clinical criteria. So they have to have at least one of bilious aspirates or vomiting, abdominal distension, or blood in the stools. And they have to have radiological features of pneumatosis or hepatobiliary gas or pneumoperitoneum. But I think then that definition sensibly takes account of the fact that there's a few babies who may pass all of those things. So they may have bilious aspirates and they may have a pneumoperitoneum, but they don't necessarily have NEC. So those who are later diagnosed as showing focal intestinal perforation should be excluded from the data. So I'm going to share our Leeds experience, and this is a kind of warts and all sharing of my dirty washing in public. So I hope you appreciate the honesty. But what I used to do until this last year was I got the quarterly report from NNAP, and I looked down the list for any that had missing data. And I then went to Badger and I went to the notes, and I sometimes contacted my surgical colleagues or the electronic record system to look at histology. And I basically filled in all of those with missing data. But if I'm honest, until recently, I didn't take much interest in the other ones. I assumed that if they were called NEC, then they had NEC if the data was complete. And looking back over the last sort of 5 years or so, our rates varied a little bit from year to year. We had a low year of 2.4% and the highest year was 7.4%, but we were always kind of within the national range, and we thought we were doing good things in terms of probiotics and breastfeeding and sort of NEC friendly policies. And then last year, 2021 data, we were pinged as a negative outlier at the lower of the two levels, so the alert level, because the rate had risen to 9.7%. So as Sam alluded to earlier, there's nothing like being pinged as an outlier to focus the mind. And I went back and did a deep dive into our cases to try and see what had gone wrong. So in that year, the 9.7% in our unit represented 10 cases of NEC reported to NNAP via Badger. So the first question I thought was, are these actually NEC? And in fact, two of the 10 babies didn't have NEC. These are babies that had been diagnosed in the referring hospital and sent to us for surgical management. And at discharge from that referring hospital, had the Badger tick box filled in to say, yes, this is NEC, yes, they have the following signs and symptoms. But in fact, two of them didn't have NEC. So one was a septic ileus and had a positive blood culture for group B strep that presented and settled with antibiotics and didn't require any surgery. And the other was an interesting baby that had a perforated jejunum from a nasojejunal tube. But some of the features on the X-ray did look a bit like pneumatosis in addition to the pneumoperitoneum. And the baby had some inflammatory raised markers, and there was diagnostic uncertainty, but at laparotomy was found not to have NEC. So in fact, if we took out those two cases, we probably wouldn't have been pinged as an outlier at all. With the remaining 8 cases, 5 of the 8 had surgery and were confirmed at laparotomy, and 3 were diagnosed using the radiological features of either pneumatosis, or hepatobiliary gas. And of those 8, 6 developed NEC in our centre, and 2 developed it in the referring hospital in a few days before referral. but they were very preterm babies who'd been in Leeds, been in our surgical centre at the beginning of life, gone back to the DGH, and then had come back with NEC later on. So fair enough, those are attributed to us under the rules. Just to reassure you that we try and do what we can to prevent NEC. Of these 8 cases that actually had it, all had received exclusive breast milk feeding, all had received antenatal steroids, and all had been on probiotics, in our case Infloram, although we're recently moving to Proprems, and all had interestingly, many had had antibiotics prior to their episode of NEC. The majority just 1 course soon after birth, but one baby had had 4 courses and one baby had had 7 courses of antibiotics. None of the babies had been given antacids, but interestingly, 6 of the 8 had had a blood transfusion within 48 hours. And our current unit policy is not to pause feeds for not to pause feeds for transfusions. So what are we doing in response to this deep dive? Well, we've decided to join the WEET study, which is looking at transfusions and NEC, to try and help get more data on that, and we'll await those results with interest. I now check, as Sam suggested, I now check all cases where NEC was ticked at discharge using either the reports function or the quarterly reports, even if the data looks like it's complete, because I want to be assured that is this actually NEC, or has the often inexperienced person filling in that form got a little bit carried away with the tick boxes at the end. And interestingly, when I've been doing that, I found that several have had focal intestinal perforations confirmed at surgery and on histology, and therefore weren't NEC. I think there's a diagnostic overlap there. One was very unclear, even after discussion with the surgeon by email. The baby had widespread inflammation, but it wasn't typical of NEC, and they'd said that in their letter. But eventually we decided, because they met the NNAP definition, they'd had bilious vomiting, they'd had clear radiological signs, we felt that it met the NNAP definition. So although the surgeon and myself were, of academic interest, weren't sure that this was NEC, it met the NNAP definition, so we left it as NEC. And I want to, obviously, prospectively, I'm trying to ensure that when I see a case of NEC, I go to the Badger record and make sure it's recorded in real time, so it gives the person completing the discharge letter a bit of an advanced information. So just to give you an example of some collaboration between our centres in our Yorkshire and Humber network, there was one baby born at 25 weeks in the local neonatal unit. They were transferred to a non-surgical NICU on day 1, and therefore were allocated to that unit as being present there at 48 hours in terms of NEC. And they had a fairly uneventful course there. They were transferred back in good, healthy condition with a healthy bowel to the local neonatal unit on day 18, and then unfortunately developed suspected NEC on day 28 with bilious vomiting, abdominal distension, and put on triple antibiotics. I'm not actually sure that they met the NEC criteria on Badger, but that because they didn't have pneumatosis or any of the other radiological features, but for whatever reason, NEC was ticked, and therefore the first NICU was allocated this case via NNAP. The baby themselves were transferred to our surgical NICU, where it was felt this wasn't typical, although the baby had a very abnormal abdomen, it wasn't typical of NEC, and they had a contrast study to exclude malrotation and vulgus. They then went on to have a later laparotomy, which showed obstruction and impending perforation, but the remainder of the bowel, apart from a very localized section of impending perforation, was actually healthy. And I've reviewed the histology, and that showed non-specific inflammation, but no features of NEC. So there's a discussion between the NNAP lead and the lead in the other NICU, the one that had been allocated the case. And in fact, I ended up sending that person the photo of the operation, which confirmed between us that we decided this wasn't NEC. And so the local neonatal unit was asked to revise their tick box. And just to show you that this was a very abnormal baby with a very distended bowel, but no features of pneumatosis or pneumoperitoneum or hepatobiliary gas. And this was the bowel at surgery with this very localized area, and not the sort of widespread necrosis that you see in NEC. So my learning points from this exercise are not everything that perforates is NEC. The words NEC often get entered into the record of the baby as quite frequently during their course on the neonatal unit, but that doesn't mean that the final diagnosis was NEC. Certainly not everything that gets triple antibiotics is NEC. The diagnosis can often change from the point of referral into the surgical centre to discharge from our unit. It's important to collaborate with your local NNAP leads across the network. And I think if in doubt, consult the surgical centre, consult the surgeon themselves, look at the electronic record, look at the histology and the operation note. But at the end of the day, we don't want to encourage manipulation of the data. And if doubt remains, but the baby meets the NNAP criteria, then it meets the criteria and it is the NEC for purposes of this audit. Thank you very much.
Thank you, Lawrence, for sharing your experience and such a good example of collaborating with your NNAP data. So we're going to open up for questions for Sam, the NNAP team, and for Lawrence as well, if you've got any questions for us. So I think we're going to enable your mics now. So do use the raise hand button. I'll try to come to you in order, but apologies if I don't quite manage that. We'll try and keep an eye on the chat as well, but if there's anything that we miss, then we can come back to you. Oh, oops. We can come back to that after the session as well. So yeah, please do raise your hands if you have any questions, and obviously you'll need to unmute your mics.
Marguerite. Marquette. Abigail Marquette.
Hello, yeah, Abby. I do apologize if this sounds like a stupid question, but I've just I just managed to get a job as a quality lead and assurance covering neonatal mainly. And I've been told that one of the things I have to work on primarily to start off with is making sure that the admission badger bit is filled in time. Because apparently it looks like our babies are having temperatures done much later than the admission, than when they are admitted. So I was told maybe look at the nurses filling in the badger, which at present is the SHOs that fill it in. So I don't know how well that would go down with the nurses. My question would be, can you change the time once you've done the admission? Can you do it in retrospect? Say if you're filling it in at 5 and the baby was admitted at 2, can you change that time so it looks clear?
Yes, you absolutely can change the time.
Okay.
And thanks for the question. No such thing as a stupid question. So I find that I was cleaning some data just the other day with my colleague, and it's pretty clear that people get the wrong year or they get the wrong day, and so the times can be wrong. We always put for the temperature, we use the time of admission because that's the one when it's done in our and our paperwork shows that. For the time of parental consultation, you have to put a minute afterwards, otherwise the badger won't have it. Most people who use badger regularly know that. So I would suggest addressing the problem. You might want to use the quarterly reports as a way of addressing that. I mean, we could make you, if you write to us, just look at the NNAP on the website. So there's one from Caroline. I'm not sure I'm going to try and pronounce your name, Caroline.
That's right. Thank you, Sam. I just wanted to ask because we've had an issue with our temperature metrics just because I think there's a bit of the language is quite vague on NNAP, what we should actually be reporting, and different units are reporting different things, especially because they say within the hour. And it just means that there's quite a lot of variance in how that is reported, which means that, for example, if we are reporting the fast temperature and other units are reporting the best temperature within the hour. I don't know what you feel about that metric, and I'll just make a bit of clarification.
I've got a very clear answer to that, which is if you look in the measures guide, you can be assured that you're doing the right thing. It's not possible for NNAP to stop people from writing down things that aren't either true or as the measures intended. But it's as my school teachers used to say to me regularly, it's your own time you're wasting, Sam. And I think they so you're absolutely right that it's the first temperature that's taken on arrival in the baby unit that NNAP is seeking to measure there, not the first temperature that's measured. So it's the first post-admission temperature. And the measures guide, I think, is pretty clear about that. If you go back to that and you think it isn't, if you could write to us, but we think that's reasonably clear, clearly expressed. Thank you very much for asking the question, though. Are there other questions?
Thank you.
Harriet. How lovely to see you.
Hi, Sam. How are you? Thank you for this. This is a slightly off piece, but a lot of I've just taken over the NNAP role in my new job, and one of the issues, the reason we have issues, is to do with linking our online system to BadgerNet. And I'm just asking if anyone else on this call has Epic or MyCare and are linking it to Badger. I'd really appreciate speaking to anyone else who's having these problems. Sorry to jump on the call just to ask that.
Not at all. If anyone who does use Epic wants to perhaps get in touch with Harriet by email, so Giles, whose surname's temporarily escaping me, Rachel, at UCL, Kendall, is the Epic expert. Giles has got a bigger problem than you've got, Harriet, if that's any consolation. But he's probably the person to speak to. We know that the Epic Badger interface messes up some, but not all of the Badger fields. And the NNAP fields, I struggle to remember which ones off the top of my head. But Giles would be the person to speak to if nobody else comes forward. And Harriet, you're in Exeter now, is that right?
Yes, yeah.
Sorry, Rachel.
There's also a BAPM forum specifically supporting people with EPR and integration. So I think to bring together shared learning, so that's a place that you could try as well.
Amazing, thank you.
Shelley.
Hi there, just a simple one for us. How do we go about the process of changing the lead person, and has it got to be a clinician?
Shall I take that, Sam?
Yes.
Yeah, if you could drop us an email, and I've put the email address in the chat. It would be great if you could, that could come from the existing lead and give us the details of the person that you want it to change to. Yeah.
And does it have to be a clinician?
Sorry, missed that bit of your question. It doesn't have to be, but if there is a clinician that we can have a first contact and a second contact. So no, it doesn't have to be a clinician.
Okay, lovely.
But we could have a second clinical contact as well.
We recognise that there are circumstances where the lead clinician, there was only one person and they become unavailable, and clearly we're prepared to be. You can explain that to us, and we can be flexible around that, or you can copy them in if they're unresponsive, because that's another challenge that we've had.
Perfect, thank you.
Is that an old hand, Harriet, or is that a new hand?
Oh, sorry, old hand.
A young legacy hand, I think we'll call it. Lawrence has got his hand up. Fantastic.
Hi, Sam. I've got a question for you. When you're cleaning the brain data, are you generally finding that people haven't put the ultrasound in at all, or are you having to change the grade on the ultrasound?
Thanks, Lawrence. I didn't put Lawrence up to ask that question, but I told you he was a great colleague. We're particularly minded to think that the differentiating between grade 2 and grade 3 IVH is an issue. So when we were thinking about introducing a preterm brain injury measure, we knew that the existing classifications were not adequate. And for that reason, as Lawrence, I think, knows, we formed an expert group. The definition of what NNAP, and now we hope the UK thinks counts as a grade 2 and counts as a grade 3, is defined in the measures guide, if you want to look at it, or more conveniently, I hope, in Badger, in the little, I think, the little question mark boxes you can hover over or click on. So yeah, I think it's about classification, but it's actually about presence or absence of cysts as well. And for cystic PBL, we suspect, I don't have great evidence for this, but we suspect that the veracity, the accuracy of people's description of PHVD might be particularly problematic. So that's why we didn't make a big deal of the reporting on that this first time around. We expect with any new measure for it to take a year or two to get to very high levels of completeness. Lawrence, I think, already knows, and probably most people on the call already know, that we've reported rates of cystic PBL and 3/4 AVH, but in some networks, the missing data was at least 30% in one of those London networks. I think it might even have been a bit higher than that. So that kind of means, how confident can you really be in their reported brain injury rates? I think that's pretty questionable. So I think it's all of those things, Lawrence. I think it's about diagnostic or descriptive inaccuracy, and it's about missing data. And I've definitely found normal ones where there has been injury, and abnormal ones where the grade's been wrong. I'm not sure I found ones where abnormality's been reported and there's been no abnormality. And I found the same with NEC, where there's been nothing mentioned, and I found that there's been NEC in the past, which is why I look at them all. Ramona, is it? Yeah, Ramona.
Yes. Hi. Hello. I'm quite new with NNAP audits, but I just have a question. For example, if you have a baby, 25 weeks gestation, who unfortunately is dying in the unit on day 2, day 3 of life, and obviously you would never meet the criteria for ROP or 2-year follow-up, or all the criteria. When we make the year summary, those specific babies are removed from the data for a unit, or they are still included?
Yeah, so the analysis makes sure that we don't NNAP doesn't penalise units, but we wouldn't include for the ROP measure a baby who died, providing you've told Badger when they died. The thing I would add to that is that we do have babies who die a little bit later, or perhaps it is thought that maybe some babies go for palliative care, so there is a final neonatal unit discharge button in Badger, and if you have babies who die, then it's helpful to record that, and that's all recorded in the measures guide. And if there's any question about that, please don't hesitate to write to NNAP or write to me. That we're really happy to engage in the fine detail of this stuff if it's problematic. But I hope the measures guide is quite helpful to you. But yeah, hopefully we've thought of some of that stuff. And for ROP, for example, and the baby who died on day 2 would not fall into the numerator or the denominator for the NEC measure either.
Mm-hmm. Because I have the feeling that actually one of our 3 babies who were missed, one of them was unfortunately passed away, so it was still included as ROP not done, not screened. So I don't know where the mistake is, us not registering as baby passed away, or I'm not sure.
The way to sorry, I'll let Rich come in a moment, but
yeah.
You're about to get your Q4 report,
yeah.
and that will say that you had ROP screening in X% of your eligible babies. Alongside that, there's a spreadsheet which describes the status of therefore the identity of individual babies. So if there's a non-adherent case, we'll have described it in that spreadsheet, right. And so you'll be able to check whether your hypothesis is correct or whether it's a different missing one.
Okay, thank you.
Rachel, did you want to come in?
Nope, that's what I was going to say. Thanks, Sam.
Fantastic.
Any more questions from anybody? Yeah, Yvonne. Yvonne, do you want to ask your question?
Might you be on mute, Yvonne? It's great to see so many old friends from different parts of the country on the line. Yvonne, do you want to ask your question? Perhaps she's got the circle.
If you're having trouble speaking, Yvonne, you could yeah. Do you want to type your question in the chat and we can read it out? Anybody else while we're waiting for Yvonne's question?
Goodness, I hope we haven't bamboozled you all. We think it's a really exciting opportunity to get your data looking absolutely perfect. I'm super grateful to you all for joining. I didn't mention in my little spiel with my highly glamorous slides that many of you who are used to NNAP will be aware that I mentioned telling us that your NEC data was complete. For example, this data validation survey and we invite you to tell us about your NEC, your infection data. So we present analyses only for units where there is complete data as well. So we're keen to use that data, because clearly describing infection rates amongst hospitals who are sure they've put it all in is more useful, and the same thing for infection. So we make great use of that. So that validation survey, I hope is helpful and hopefully pretty straightforward.
So Yvonne's popped her question in the chat.
Great.
So referring to Lawrence's neck example, what should be entered instead of suspected neck, as I imagine the reason the referral to surgical unit is suspected neck?
Yeah, well, I think at the time that you're referring the baby, you can put suspected neck, and certainly in the letter and in the free text of the letter and everything. But I think in the discharge form on Badger, where it says was NEC diagnosed on this admission, I think it would be helpful if there's not certainty about that to not tick it. But I think you have to do the best you can, and if you tick it, then that's fair enough. And I know Sam's got a system where he goes back and looks at when he's validating his data, he's also looking at the babies that have been referred into his centre to see whether they came mislabeled as well. I have to say I haven't been doing that so religiously up until now, but I think I will be now. Because of our 10, it turned out that 2 of the 10, which probably pinged us over the line, actually were misdiagnosed.
But you'll see that in that case that Lawrence was describing, there were at least 3 clinicians thinking about whether this patient had NEC. Now, NEC is a devastating diagnosis that caused death 40% of the time. So it's reasonable for people to think about whether it really occurred or not. Lawrence and others amongst us put huge amounts of time, effort, and other people's money into trying to prevent NEC. So I think the surveillance activity it's a bit laborious, but it's worthwhile. So we thank you for your engagement in it. Are there any other questions, or should we finish a minute early?
I've got a few practical notices that I just wanted to give before the end of the session as well. So perhaps we can use the last minute or two for that. So yeah, so if anything does spring to your mind after that you want to ask us, do drop us a line. We learn from our dialogue with you, and we improve the audit through that dialogue. So no question is stupid. Please just drop us a line. And NNAP at rcpch.ac.uk is the best place to start with that. So just a couple of updates. We've just put out our 2023 measures guide. It is provisional. We're still discussing the final set of metrics with our commissioners and funders. I've put a link to that in the chat, but we'll also be sending out a newsletter tomorrow with the key dates that we've gone through today and all the links you need. Also, please look out for an important update from us next week about the national data opt-out. We've received an exemption that only applies to England, but we'll be sending in all you need to know about that and updated resources next week. So do look out for that. It's important that you take note of that. From today, we'll be sending a feedback survey, and an attendance certificate should be coming to your inboxes very shortly after we finish. Please do respond to that so we can make these webinars better. And if you've got any ideas for things that you'd like us to run a webinar on in the future, please do let us know, because we can look at putting on other webinars as well. Anything that you think would be helpful. So I think, unless you've got anything else you wanted to say, Sam, I think we'll round up and say thank you to everybody. And we finished 1 minute early.
I thank you, Rachel and Lucy, for organising it. Very nice to see you. Thank you all.
Thanks, everyone. Bye.